everyone, and welcome back to the Down Syndrome Center podcast. I'm your host, Dr. Kishore Volodi, and you may have heard, if you are on the news or you have a cellular phone that beeps with news stories, that there is a big development in COVID vaccines that have come out in the last week, and that would be being able to vaccinate children between 5 and 11 years old, in addition to information over the last month or two about booster doses as well. So I was like, man, who do I talk to when it comes to things COVID and Down syndrome? Oh yes, Andy Nowalk. So Dr. Nowalk, thank you so much for joining again on the podcast.
I have this incredible sense of deja vu.
So let me open this podcast with what a family said to me earlier this afternoon, which was in a pleading voice, "When will this end?" Meaning COVID. And I said, I don't know, but could you give us an update on COVID in general and pontificate with your ID mind where we are headed?
I think when we talk about when will this end, I think we're going to have to take a step back and think about infectious diseases in general. You know, we have in the history of mankind really had one major victory where we completely eliminated an infection. That's called smallpox. We're close with polio, but smallpox, with the last person with smallpox was diagnosed and followed, I think, in the late 70s. And so, that was the end of smallpox. And that is our one big success story. And so I want people to remember that. In that, we had good vaccination for smallpox for actually a century. And it took a exhaustive, focused public health effort to completely eliminate it. So I know a lot of folks say to me, when are we going to be rid of COVID? And my point to them is probably it will be a long time before there's no COVID anywhere. I think the better question is, when are we going to get this under control? When are we going to get to a point where our lives are not upended by the next surge and the next surge? And, what has become clear there is we need, I think, three things. The first thing is we need the virus to stabilize, and we need there to be not a continuing string of different variants. Believe it or not, there is a little bit of a hopeful sign in the Delta variant. If you look at the United States in the first 18 months of this pandemic, the first, I'd say 13 to 14 months were waves of different variants. There was the OG strain, and then there was the Alpha strain, and then the Brazilian strain, and then, they were calling it by countries, and then they were giving it Greek letters, and very confusing. And I assumed, like everyone else, that when Delta came to the United States and around the world, what we would see is Delta would be here for a bit, and then the next strain would come. And people were talking about Mu and Iota and this and that. And, never have I wanted to study Greek letters less. And a funny thing has happened. If you go to the CDC website, where I get about 95% of my knowledge, and you look at the strains in the United States or the variant, it hasn't changed for now about 6 months. It's Delta, 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 Delta. And that has caused us many problems. It's more contagious than the prior strains. There's a variable signal. It's more severe. I actually don't believe that to be true. But it's not changing. There aren't other variants. The Mu strain was described and never really made a difference anywhere else. So that is actually one of the first hopeful things that's happened to me, because if you have the same strain, it's easier to design your interventions against it. So that's number one. We need the strains not to vary too much, and that's happening. Number two, we really, 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 really need to get either everybody infected, which is not what we want because millions of people have died, or we need to get everybody vaccinated. So that's our biggest challenge right now, right? I mean, our biggest challenge is getting buy-in as a society to vaccination. And, we are, when you look at the United States, I think we're a little bit around 70% with at least one shot. It's not enough for a strain this contagious. And then the third piece of this is that we're going to just need time. We're not going to be done with this holiday season. In fact, we'll probably have another more limited surge than we had last year. And I don't know that we'll be done with it next year, but if the strain stays pretty constant, our next set of boosters will be Delta boosters, and they will be very targeted against that. And if we can get more people to take the vaccine, we have a chance to reduce this to the point where the outbreaks in a local area will be like the summer when we had in a lot of areas in the United States, like Allegheny County, had some days where there were 5 people who were new cases. When there's 5 people, we can find all those people and isolate them better. So that's when it'll end. But is it going to end soon? No, it's not. We had a chance to do that a couple of times with vaccine and we didn't take it.
Yeah, and I think that really hits the point home, and really is going to take us as we go through this podcast into vaccinating our younger ones at this time. But before we get to that topic, a few weeks ago, maybe a month or two ago, I had emailed you because I said, hey, we've got a couple of kids from clinic who are in the ICU, and we had a couple more that were on the floor, and I put it out to our national Down syndrome listserv saying, hey, are people seeing an increased signal? And it turns out it was just a bad week, but we weren't seeing that continuing. Have you heard any updates on Down syndrome specifically along with COVID, whether it be children or adults? Are we seeing anything different now?
I don't think we're seeing anything different, but as time has gone on, what have we said every time we've talked? We're smarter than we were last time because we've learned more. So what we've learned over time, and this has become very clear, is that people with Down syndrome do not seem to be exquisitely susceptible more than the next guy. This virus, unfortunately, is contagious enough to infect everybody. But when they get COVID, they do seem to do worse. We should not be surprised by this. I mean, we've seen this with RSV. We've seen it with influenza. We've seen it with all-comer pneumonia. So, a virus that causes pneumonia is kind of designed to be hard on people with Down syndrome. So we've definitely seen that. I think the reason that you and I have seen more severe cases more recently and had that opportunity is simply because we're pediatricians. And for a long time, if you looked at the rate of COVID in individual age groups, the bottom age groups were 0 to 4-year-olds, slightly above them were 5 to 11-year-olds, slightly above them were 12 to 18-year-olds. They were the bottom 3 for a long period of time. And now that vaccination has happened, it works. And so the lowest incidence groups are now the 65 and up and the 50 to 65-year-olds because we are the most vaccinated. And when you look at who's on top, it's the 5 to 11-year-olds and the 12 to 18-year-olds. And not far behind them, incredibly, the 0 to 4-year-olds. So, and they're pretty resistant to infection. So I think why we have seen an occasional really bad case now is there's enough COVID in our community in children now with the highest rates they've had in the entire pandemic that we're going to see bad things happen to those children. And therefore, proportionally, a kid with Down syndrome is more likely to get COVID now. And we know that he'll do worse or she'll do worse than a child who doesn't have Down syndrome. And so we get to see these very severe cases. And that's inevitable. And we've had more deaths in children from COVID in the last 2 months than almost the 12 months before that added together. We are seeing, unfortunately, what happens when you have a whole age group that is unvaccinated, and then you put them all together in a school and let virus be transmitted.
Yeah. So where are we at in terms of pediatric death numbers? It's over 700, I think, at this time, right?
If you add in the MISC, the inflammatory syndrome, it's over 800. And, we're assuming that we're picking up every death. So I would say very likely we're getting close to 1,000 deaths. And one of the things I have to do a little rant, and I apologize, Kishore, and you knew this was coming when you asked me that. One of the things I have seen in the media that drives me bonkers and actually infuriates me is the casual dismissive of dead children in the framing of this pandemic. I've seen this from fairly bright people in the media and all over social media that says some kids are dying. Number one, first time I've ever heard people be casual about dead children. I was raised in a country where dead children were a bad thing. Yes. And number two, I just want to put in perspective how terrible this is compared to past epidemics of anything in children. In the worst measles epidemics in the 50s, we would have 500 deaths. And, we're talking about 1,000 dead children this year. In the worst, diphtheria epidemics, we'd have 500 deaths. And we're talking about 1,000 dead children here. So we don't think of the 50s and 40s and 30s fondly in terms of infectious disease. Kids died all the time from meningitis, diphtheria, polio, all those things. And yet we're being dismissive when we're seeing numbers that are way worse than those times along the way.
Yeah.
The worst pandemic flu season we ever had in terms of killing children was about 200 children in the United States. So we have fivefold that for this virus alone. This is a lethal infection in many children. And the terrible thing is many of those deaths were preventable. You can't blame the 50s. They didn't have a vaccine. And when the 50s became the 60s and we had vaccine, we eliminated deaths from measles. Same thing for polio. We really didn't like kids dying from polio, so then we vaccinated them all and got rid of that. For some reason, we think that that's controversial with COVID. It makes me very upset.
So I appreciate you sharing that, because it does really put things into perspective. And you're right. So much of the media is around how this is not a serious condition for children. And then we've shared on this podcast about every time we're on, it's another 100, another 200 kids have died. And like you said, preventable deaths. And I guess as we talk about prevention and vaccine and whatnot, some really big news that people are celebrating. And it's been going on for about a week or two, where people are like, oh, this organization is now approved. And now this organization. So is there an approved COVID vaccine for children 5 to 11 today?
Hallelujah. Amen. There is. So the Pfizer vaccine, which is always ahead of Moderna in terms of these, although Moderna is never far behind. The Pfizer vaccine presented its data to the FDA and then the CDC, which is the way things go. And then panels at the FDA, and then the FDA chief approved it, and then panels at the CDC, and the CDC chief approved it. And what the Pfizer vaccine showed is what pretty much every other trial in every other age group has showed. It is safe, it is effective, and it's going to save lives in those children who are vaccinated.
And does it matter where someone would get it? Like, I know a lot of the practices locally here, pediatric practices, are starting to stock the vaccine. I know a lot of the pharmacies are. I know this is a big initiative of the current administration to get it out. So does it matter where they get it?
I think about this as I would think of Dr. Seuss. I'm a big fan of Green Eggs and Ham. And if you remember Green Eggs and Ham, let me paraphrase Sam I Am. I would get vaccine on a train. I would get vaccine on a plane. I would get vaccine here. I would get vaccine there. I would get vaccine everywhere.
All right.
So, much to learn from Dr. Seuss. If it's at your pediatrician's office, get it for your child. If it's at the pharmacy, get it for your child. If I happen to be walking down Penn Avenue in Lawrenceville and you see me with random vaccine in my pocket, stop me and get vaccine. I mean, just go get it. That's how we're going to save some lives in these children. Today in Pittsburgh, we're vaccinating kids in community practices. And I look outside and I think we are saving lives right now. It's a beautiful thing.
It's very beautiful. Yeah. And so let me ask you about the dose. So in this 5 to 11-year-old age range, are they getting the same dose that you and I have gotten for vaccine?
So they're not. And it's another vignette, a story of how we make vaccines safe. So when the studies were beginning to be done in children, knowing side effect profiles and everything in the other studies that have been done, because every one of these studies has stood on the shoulders of the one before, learned from it, and tried to do even better. They said, well, given that children are smaller, we're going to experiment. We're going to look at the doses. And they looked at 3 doses, the adult dose, which for discussion's sake is 30 micrograms, 20 micrograms, and 10 micrograms. And what they found was when they measured the immune response, they could induce the same level of antibodies in a child as in an adult with 1/3 the dose. So the 10 worked just as well. And the side effects were significantly less in those children. So therefore, when they went ahead and did the big trial, they did it with the 10 microgram dose. And what they found was that 10 microgram dose not only induced the same amount of antibody, it seemed to provide the same protection. And I'll tell you one lovely thing about that. They did these studies in the age of Delta virus. And so they measured this vaccine against Delta. So in some ways, just between you and me, I actually think this vaccine proved to be even more efficacious in the children because it was up against a tougher virus that it wasn't perfectly designed against.
Now, what if a child, we've been getting these calls for 11 and a half year old, they're at that borderline between getting the 12-year-old dose and getting the 11-year-old dose. What would you say if a family says, well, should we just wait 3 more months and then he'll be 12?
I would say get the vaccine now because the virus is all over the place now and it's killing children now. God forbid someone says, I'm going to wait to get the 12-year-old dose and they wait a month, but at week 2, that child ends up with COVID and ends up in the hospital or the ICU, or 2 months later gets MIS-C, or infects their 78-year-old grandmother who had made it the entire way through the pandemic and then was getting chemotherapy for a new diagnosis of lymphoma and got COVID and died. Those things are happening across the United States right now all the time. So get it now, get it at the age specific dose that's appropriate. That's the best thing to do.
And then another question we get, especially in this population, what if my child had heart surgery? Hearing the stories of some of the teenagers who earlier in the summer were getting some myocarditis associated with the vaccine potentially. What would your thoughts be about a 6-year-old who had their heart repaired? Should they be hesitant about receiving this vaccine?
So, let's talk about myocarditis because I think as this has come up, it's been one of the things that we've seen in the news a lot. I will point out again that we know a lot about it because we're dedicated to vaccine safety. So we have been looking for cases of myocarditis and studying them since we saw the very first one. I heard about this within weeks of teenagers starting to get vaccine, and it was followed very carefully by FDA and CDC. And we actually have a lot of data on it. We know that, let's pretend that 5 to 11-year-olds are teenagers. We know that the rate is somewhere around 1 in 100,000. Maybe a little bit more if you're a male, maybe a little bit less if you're a female, but 1 in 100,000 or 10 per million is a good number. So let's say we vaccinated 1 million kids and we got 10 cases of myocarditis. What we have found about these cases of myocarditis is that they're very mild. The vast majority of these kids didn't need any upper level of care. They stayed in the hospital for 2-3 days. They went home. It in fact is curious in that we picked up this myocarditis and it is much, 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 much less severe than normal myocarditis from any infection, including COVID, by the way, because COVID myocarditis kills people. So let's take that same million and let's say, Kishore, we don't need to vaccinate those kids. This is a mild infection. So remember our first million that we vaccinated, we had 10 cases of myocarditis and they all went home and their parents were a little scared appropriately, but relieved when they came home and were doing fine. That next million, we don't want to vaccinate them. We're just going to let them get COVID. It's harmless. Well, 100 of those children would be dead. So here's the mathematics for you. Let a million 5 to 11-year-olds get COVID. 100 will be dead. And if you're like, he's making that up, no, on the CDC website today, reported cases in the United States in that age group versus the number of deaths is a ratio of about 100 in a million. So about 1 in 10,000 children dies from COVID in the 5 to 11-year-old age group. So those are real numbers. I would much rather have 10 children get mild myocarditis and I can reassure them that they'll do fine and then go home than bury 100 children. And I don't see how anybody can dispute that.
You know what, Andy Nowalk, you are a statistical mastermind. I love how you put that. That's exactly the way we should be thinking about this in terms of risks and benefits, right?
Risks and benefits. In the hands, you know what, you may notice I am a little bit more confrontational and a little more strident than I have been in past podcasts. I'm tired of people using hand waving to try to dismiss things and then say, these vaccines, we don't know much about them. We've given 400 million doses. We know more about these vaccines in terms of number of doses than probably the last 5 vaccines we've given to children, you know, and some of them we've given for 20 years. We know a ton about this vaccine. You know, it saves lives. It will do that in children. And when people get all worked up about it, I get frustrated. Children are dying from a preventable disease today. How is that a good thing?
And in thinking about other preventable diseases, and also the theme of viruses coming earlier than they ever have before, we are definitely starting to see influenza show up. I think earlier than we normally would, and especially in the numbers that we're seeing. So the flu shot, I know you're a big proponent of that. And a question that has come up is, if your child is due for the flu shot and now is also available getting this COVID shot, which one should they get first?
Well, the good Lord has provided us with two arms. So
Yes.
and it's almost as if he had wanted us to get one in each arm.
So it's safe.
I would say it's very safe and very effective to get both shots simultaneously. So if you were to visit at your pediatrician or family medicine doctor's office, or you're at Rite Aid, get them both at the same time. We've done a little experiment here at Children's Hospital in the last 4 months that Kishore and I have been inadvertent investigators in, which is what happens when you let loose a virus that we have no vaccine for in a community of young children. That virus is called RSV. When we put everybody back together again in the spring and the summer, RSV came back as we predicted it would, and it has kicked our butts.
Yes.
And we've had record census at our hospital and days with no beds available. And that's primarily because RSV is very transmissible and we have no vaccine against RSV. We do have a very effective vaccine against influenza. So get it, because that way we'll be able to keep our hospital functioning in the middle of this winter.
Yes, for sure. So now I want to change gears just a little bit. We have listeners to this podcast that will say, you guys always talk about pediatric things. What about adults with Down syndrome? And I think a very important topic that we could cover today for those 18 and older with Down syndrome would be things like a booster vaccine. And the CDC has continued to include people with Down syndrome as a high-risk category, and adults with Down syndrome over 18 are able to get a third dose of the vaccine. So I guess my question for you is there any information on this vaccine for how adults with Down syndrome have responded to doses 1 and 2? Do they respond like everybody else, or does their immune seem to wane faster?
We don't have a ton of organized data here, but you and I have begun to hear around the world a little bit of the very preliminary data. So this is me doing something I really hate, talking about preliminary data and things that are not completely published and vetted yet. But there is a suggestion that people with Down syndrome don't respond quite as well to the COVID vaccines as people without Down syndrome. And this, again, is not a surprise. The data that we have from past studies of pneumococcal vaccines and influenza vaccines and a number of other vaccines have suggested that people with Down syndrome do respond, but they don't respond quite as well. So they don't derive quite as much protection as people without Down syndrome. So this seems to be the same, not a surprise to us. So what does that mean for me? Even more important that you get a booster, because if your antibody levels are relatively low, you're in more need of a boost of those antibody levels with another dose than someone whose antibody levels were okay. And that's actually why at the governmental level, there's still a lot of disagreement, even among governmental agencies, CDC and FDA and the administration, about boosters for all. But everybody agreed that the elderly and people who were immune compromised or whose immune systems, everybody agreed that those folks should go ahead and get a booster because it would benefit them. And I include our loved ones with Down syndrome in that group. They don't respond quite as well to the vaccine. They need more help. They should all get boosters right away.
So a question that I get was, if they did not respond as well as expected to the first 2 doses, should we expect them to have any improved response to a third dose if they're not responding to the first 2 as we would expect?
So, what we've seen is the vast majority of people, almost every single human being who gets a third dose gets a nice bump in antibodies.
Okay.
That does not mean it's foolproof and that they should then run around the community unmasked and kiss everybody they see, but it's going to help protect them. And boy, don't we that's what everything we do for our loved ones with Down syndrome. Yeah. We try to help protect them. We recognize that no protection is perfect, but we're still going to put seatbelts on them every time. We're still going to teach them basics at school about being safe around bus stops and cars and things. Yeah. We keep them away from hot and sharp objects, and we should vaccinate them for the same reason. We want to protect them as well as we can.
All right. And then here's my final question for you in your pontificating mind. What do you
I'm on a roll today. I apologize.
what do you see is the likely time frame for the younger than 5 to be able to be vaccinated?
So I think that that's going to be several months. I don't think it's going to be right away. Those studies are in progress. Um, and I predict what we're going to run into is the exact same um, sort of media and social media misinformation, which honestly is now one of the leading causes of death in the United States, misinformation. And you're going to see infants, it's harmless in babies, that children under the age of 4 never get COVID. Well, children under the age of 4 get COVID. Interestingly, between you and I, the death rate in that age group is higher than it is in children 5 to 11. So they are actually more likely to be severely affected. And in particular, what's heartbreaking in that crowd, it's very frequently premature infants and children with disability who are disproportionately affected. So, we do so much to protect those children that I hope people will recognize this is no different than any of the other age groups. But we're not going to put a vaccine in a single one of them until we know it's safe, because that's what we've done on every step of the way.
Yeah. So you're saying it won't be a Christmas gift, but somewhere around 2022 sometime is when we should start to expect to see some of these studies coming up.
I would agree. Yeah, I think that's
perfect.
most likely. And, I think that many of these studies, when you saw the studies just published for Pfizer, several thousand children were involved in it. They don't ever comment on how many had Down syndrome. And what I would say to everybody in the community is that doesn't matter. These vaccines work, and they will work in people with Down syndrome. Maybe not perfectly, but they'll work. And, I didn't let a lack of Down syndrome data in adolescence deter me from the moment it was available vaccinating my son who's 15.
Yeah. Yeah, I think that's a powerful statement. I think it's oftentimes where we say that vaccination, that's our private decisions, but my whole family's vaccinated. My brother got his booster just a couple of days ago. This mess around with, and especially with our community of friends with Down syndrome.
You know what? That's like saying drunk driving is a private decision. The reason we have laws against people drinking and driving is because that private decision leads to a public health disaster. People die, people are injured. And this is no different. People's decisions to not vaccinate, which they regard as a private decision, lead to deaths in other people who couldn't be vaccinated, particularly those immune compromised, but also others who were vaccinated, and no vaccine's perfect. If you look at the United States right now, a distressing number of people who are elderly and vaccinated are dying because it's not a perfect vaccine, and COVID's a severe disease in that age group. Yeah. So I would really encourage people listening to recognize vaccination is not a private decision. It's all about the community you live in and whether you want to protect that community, both the little community, which is you and your loved one with Down syndrome, but also the big community. And, lots of the people in that community take care of your person with Down syndrome. I rely on everybody being healthy for my son at his school, and his speech therapist there, and his nurse who comes in to help him with his diabetes. I need all those people to be healthy too. So it's not a personal decision for me, it's a community decision, and we love our communities, so we should be passionate about protecting them.
Well, thank you so much again, Dr. Nowalk, for joining for yet another podcast, sharing your knowledge. I feel like every time I'm at the end of one of our podcasts, I've learned so much, and I think there could not possibly be any other question. And then the questions start coming in, and I start to store it up for our next podcast. So I appreciate your willingness to come on and be with us again today. Thank you.
Anytime. I'm happy to help. You know that.
Awesome, awesome. And for our listeners, as you know, we love to get your emails. So please do email us at downsyndromecenter@chp.edu and let us know what are the questions you would like us to answer, whether it's COVID related or whether it's any other topic. This is our joy to be able to bring this to you. And in order to be able to bring this to you, of course, if you would like to partner with us at the Down Syndrome Center, partnering with what we are doing in our community and around the world with this podcast, please do go to www.givetochildrens.org/Down Syndrome Center, Down Syndrome Center, and we will gladly partner with you in this. But until next time, bye-bye.